Okay, everyone, so this is a brief explanation of the progression from H&P to discharge summary and how kind of this process goes. So we'll start off with an admission. Always start off with your admission navigator, your allergies, your history. Mark everything as reviewed as you go along, do your med reconciliation, do all that stuff, put in all your orders. Then you come and you start doing your notes. It's important that you put in your orders first because there's things that are pre-populated in the note from the orders. Okay, so we'll start off with an H&P. As we all know, we come H&P, site-specific HP 2026, so it'll be Wayne, Caldwell, etc. And you come in and you just do what you've been doing so far, F2, F2. I wanted to point out past medical history significant for. So you do an exhaustive history that's pre-populated here, but in this part, in the written part, it's whatever is significant. So stroke if patient is hyperlipidemic or has heart issues or diabetes. The cholecystectomy 30 years ago isn't important. All of this other stuff is, again, it's pretty self-explanatory. You come into your assessment and plan, problem list, bulleted so that it's easy to adjust, incidental findings for follow-up. That's nothing other than that smudge on the x-ray or the lab work that you're not doing anything about. Anything that doesn't have to do with acute problems or that you're not going to address in the hospitalization, just put it in there for outpatient follow-up. That's a huge issue for patients, and it's also a huge liability issue. Additional non-acute findings. Some people put physical exam findings. Some people put, patient requested this, that, patient was upset. Some non-acute findings, that BKA that the patient had a long time ago, whatever. It's just what you think is important for everyone to know. Then, again, everything is pretty self-explanatory. This part here was requested of us by billing. Whatever you think your intervention is that qualifies someone for inpatient, just write it in there. It should be in your assessment plan anyway, but it apparently helps with billing. Okay, so I have in my notes here an example of the H&P. This is how it looks. Nothing exciting. Great. Next day comes in. Actually, before the next day, always go to the hospital course area and write a really brief blurb of why the patient was admitted. In this case, admitted for weakness and a lung opacity. If I want more details, I'll go to the actual H&P. So that's done. Now, next note, progress note. Use the site-specific template, Prague 2026. You come in and you'll notice the hospital course is already pre-populating. You go into all your notes, you find your H&P, copy, paste everything between the red lines. Done. Now you come in, you look at the problems. Since they're bulleted, you don't have to worry about anything. Sputum culture pending here, for example, positive 9.5 for staff. Same thing. Here something is pending, updated. Kind of close the problems as you go, whatever is needed. Use a little SOAP format. And let's say in this case, for example, this particular patient developed SBT today. In this case, it's September 6th. So I opened the note up. I finished one up. Here it is. And you'll notice I have SVT, why the SVT, RT, objective, you can add whatever the patient's feeling, blah, blah, blah. You put that in there. I wanted to point this out. I never put in dosages because that should be pre-populated in your note. This is the plan. Now, in the hospital course, I'll go in and I'll do 9.6, developed SVT, had RT. Okay? That's it. Hospital course. The significant thing for this day was the SVT and the RT. I want more details. I go to the actual progress note. I got all the details that I want. If there was an RT, there should be a significant event note. I can open that up. That's it. You don't need to be redundant and write the entire plan in the hospital course because it's already in the note. The hospital course does not take the place of the note. Okay, That's it. You did your thing. I did want to point this out because some people do a physical exam and the additional non-acute findings. In this particular case, where SVT is a very acute problem, the cardiac exam should not be here. It should be under the problem. Because remember, the name of the game now is justifying your diagnosis. Okay, next day comes in. I'm going to do a progress note. Since I already have a progress note, I just use the little arrow here and I copy forward the note from yesterday. Done, and I do the same exact thing. In this case, for example, yesterday it said RT was called, palpitations, all this stuff. I already have a completed note here. And you'll see that here I have SVT, likely secondary to hypokalemia, resolved with treatment, no chest pain, no pain. You just adjust the problems as you go. That's it. Nothing else. Very easy. In these cases, once you're doing your notes, again, you'll always have your progress, your hospital course being pre-populated, all that good stuff. Very easy. Done. If I happen to be working overnight and something happens with this patient and they call me, oh, this patient had an RT, I go into the chart, I open the summary page, and I know, okay, this patient was admitted for this. Oh, they had an RT yesterday because of SVT. I need to learn more. I come in, I look at my notes. Oh, look at this. Progress note, they had SVT, they have a critical care note, they have all this stuff. We're done. It's easy to find. That's the reason for this. Easy access. Okay. Lastly, we have a patient that we're going to discharge. You go to discharge summary, you open your site-specific template, site DC, and yep, you guessed it. You go to your progress note, you come in, you go between the red lines, there we go, copy, paste, and you start closing out all your problems. In this case, you know, your cardio follow-up, hypokalemia, your potassium supplementation, follow-up potassium in a week. Same thing, you just go through all your problems. I have a finished one that I'll show in a little bit. I did want to point this out. So, did show insight and did use teachback are huge, not only for the patient, but also for you, for liability purposes, because it's important to document that the patient or the representative understood what the plan was for when they left the hospital. That's why this isn't pre-populated as did. It's there for you to add it to make sure. Everything else is pretty self-explanatory. I have a discharge summary here just to look at. When a primary care provider gets this patient, they'll know the patient was admitted for X. This is the only significant thing that happened. You know, do they need to know that the next day the patient got better? No, because they expect that. The patient got discharged on the 8th, because it is when this discharge summary is done. And for the SVT, follow up with cardio, continue diltiazem as prescribed, hypokalemia, outpatient review in 1 week, maybe the multifocal capacities, lung follow up in 2 weeks, whatever that is, but just finalize everything. Nice and easy. Hopefully this took less than 10 minutes, I'm not sure, but it took me 10 minutes to explain. And each particular note outside of the H&P should be much, much, much quicker to do than that. So hopefully, if you did not enjoy, maybe it provided some help in understanding how these notes are supposed to work and why the documentation is important. Thank you, everyone. Bye-bye.